Hello, and welcome to the 19th IAES postgraduate course. My talk is on the workup of thyroid nodules. Thyroid nodules are very common in the general population and are detected in up to 50 to 60% of healthy subjects. Palpable nodules in up to 7% and non-palpable nodules detected by ultrasound in 20 to 50% of the population. Thyroid incidentalomas are increasingly detected on CT, MRI, or PET scan. Fortunately, thyroid carcinomas occur in 5% or less of thyroid nodules. As most nodules don't cause clinically significant symptoms, the main challenge in the management is to rule out malignancy. We start with the history and physical examination, and these features of increased risk of malignancy are familiar to us. In the workup of thyroid nodules, I took the recommendations from the AACE and ATA guidelines, as well as the European Consensus Statement. First up, we checked the thyroid stimulating hormone, TSH level. A low TSH level indicates either subclinical or clinical hyperthyroidism. And we follow that up with a check of the free T4 and free T3 and a thyroid scan, which can detect an autonomously functioning hot nodule, which is rarely malignant and doesn't need to be biopsied unless the ultrasound shows suspicious features. A high TSH can indicate Hashimoto's thyroiditis, and so we check the autoantibodies, anti-TPO, and anti-TG levels. Serum thyroglobulin measurement is not recommended for the diagnosis of thyroid nodules. However, routine serum calcitonin measurement is controversial. In the European Consensus Statement, it supports the use of calcitonin measurements because elevated levels are synonymous with MTC. The ATA does not recommend, and the AACE supports it being used in positive family history of MTC or MEN2 or indeterminate cytology. Secondly, as a diagnostic test, the ultrasound is the most commonly used imaging study, and it detects the size of the thyroid nodule as well as the number of thyroid nodules, and more importantly, features of malignancy. It also images the cervical nodes. Although ultrasound does not accurately determine malignancy, there are features that are suspicious and increase the risk of malignancy, such as solid and hypoechoic nodules, microcalcifications in the nodules, nodules that are taller than wide, nodules with irregular margins, and extrathyroidal extension is a near certainty of malignancy. This is a pictorial chart taken from the ATA guidelines and shows the risk of malignancy. The features mentioned previously are shown in the topmost category here with the highest suspicion and 70 to 90% risk of malignancy. This chance of malignancy drops to 10 to 20% in the intermediate suspicious category. This is a table that summarizes that of the three main categories: low risk, intermediate risk, and high risk ultrasound features in the AACE and ATA guidelines. This then determines the need for fine needle aspiration biopsy according to size of the nodules. So for the low risk category, we would biopsy nodules larger than 1.5 to 2 centimeters. In the intermediate risk category, we would biopsy nodules larger than 1 to 1.5 centimeters. And in the high risk categories, any nodules larger than 1 centimeter, we would biopsy. For nodules smaller than 1 centimeter, we would biopsy, especially if it is clear on the ultrasound there is extrathyroidal extension or positive cervical node metastasis. A way to standardize this reporting on ultrasound by radiologists, the THYREDS system is being used. And here you can see that the various categories in terms of points can be converted to a score, and that then determines the THYREDS level 1 to 5, 5 being the highest, and the need for biopsy for lesions larger than 1 centimeter. Ultrasound of the cervical nodes that show enlarged nodes with or without intranodal cyst or microcalcifications, round shape, or loss of hilar should be biopsied. And in addition, thyroglobulin levels can be determined on the cytology washings. Ultrasound elastography is a method that evaluates tissue stiffness of the nodules through applying external pressure via the ultrasound probe and measurement of nodule hardness. When combined with ultrasound suspicious features, the sensitivity of detecting malignancy increases to more than 95%. Nodules with increased stiffness should be biopsied, and this test can also be used to supplement indeterminate FNAs. The third test, and the most accurate and cost-effective method for evaluating thyroid nodules, is the fine needle aspiration biopsy with a sensitivity of more than 95%. This is performed using the 23 or 25 gauge needle. The ultrasound can be used to guide the needle to sample the solid component of the nodule. More than one sample pass can be done, or with the aid of a cytotechnician to reduce the non-diagnostic rate, which should be less than 10%. The cytology is then subjected to the Bethesda system reporting. And here are shown the 6 categories from non-diagnostic rates, non-diagnostic category, the benign category, atypia or follicular lesion, follicular neoplasm, suspicious or malignant categories, and the corresponding malignancy rates as shown. And with it, we can also determine the management algorithm according to the various categories. Finally, ultrasound-guided core needle biopsy, rarely used, can be done cautiously in anaplastic or thyroid lymphomas. And the monitoring of benign thyroid nodules with ultrasound can be done in 1 to 2 yearly intervals, depending on the suspicion of the nodules on the ultrasound. So in summary, ultrasound and fine needle aspiration biopsy are key diagnostic modalities in the workup of thyroid nodules. Ultrasound-based categorization of the malignancy risk guides the indication for ultrasound-guided fine needle aspiration. And the cytologic classification of FNA guides clinical decision-making and management. Thank you.